Okay, welcome to WiLing Wednesdays, live webinar series on Hodgkin lymphoma. For those of you who are not familiar with Women in Lymphoma, we are an international group committed to supporting and advocating for greater leadership of women in lymphoma globally through advocacy, networking, and education. Our chair is Professor Judith Trotman from Australia, who has really spearheaded much of what we do, and we're very indebted to her. We currently have over 300 members. We're also grateful for the support of the Snow Dome Foundation, and particularly for Anna Steiner, who is our administrator, who keeps us all on track and organized. I'd also like to thank our sponsors, MSD and Roche, for their support of Women in Education, Women in Lymphoma's education in lymphoma. So thank you. So today we have a new format.
So
okay.
Okay.
My computer froze. I have another computer ready, so apologies for that. Hopefully that won't happen again. But we have a new format for today. We're going to do some cases in Hodgkin lymphoma, and we have put together just an amazing panel of international lymphoma experts, including Dr. Anna Sureda from Spain, Dr. Astrid Pavlovsky from Argentina, Dr. Kerry from British Columbia, and Dr. Leanne Berkahn from New Zealand. So I'm going to show the cases, and we're going to go around and discuss each of them, and we would welcome any comments or questions from the audience. We'll also take some questions at the end. So I'll be sharing my screen, and again, apologies in advance if my computer, I don't know what's going on here, but I had a little glitch. So sharing my screen. Can everybody see that?
Yes, you can see the screen.
Okay. So here again is our fantastic international panel. Here is our first case. So this is a 19-year-old woman with favorable stage 2A disease. She initially noted a right neck node on self-exam without constitutional symptoms or pruritus. Her family history is notable for a mother who actually died of breast cancer related to radiotherapy she had received for Hodgkin lymphoma as an adolescent. So this was a particularly emotionally charged decision-making in this case. She underwent an incisional biopsy, which was consistent with classic Hodgkin lymphoma, nodular sclerosis subtype. The RS cells express CD30 and CD15, negative for CD20. Her PET is shown here. She had disease within the right supraclavicular fossa, the mediastinum, largest conglomerate measuring 4.4 by 3.4. And she also had some sub-centimeter nodes that were FDG avid in the right pericardiac phrenic region. So a fairly large distribution sort of geographically on her scan. Her sedimentation rate was normal. So this 19-year-old woman, favorable stage 2A disease, how would you treat? We're going to go through and ask each of our experts on how they would optimally want to manage a patient like this, both regardless of insurance or those sorts of issues, and also anything that you would do differently in the setting of COVID. This was actually a case from a few years ago. So I'm going to start with Anna. And ask you, how would you treat this patient? And then to also comment if you did a PET after 2 cycles and it was a Deauville 3 versus a Deauville 2, and how would that impact on what you would do with this patient?
Okay, thank you very much. And first of all, I really would like to thank all of you for the invitation to participate in this panel. I think it's really a fantastic opportunity to share all these cases and all these views with you. So going into this specific case, so we are facing this very young lady with favorable stage 2H disease. I think it's very important, I mean, the family history of the mother having breast cancer after radiotherapy, also for Hodgkin lymphoma in the adolescent. So probably that would be one of the reasons I would not treat the patient with radiotherapy. So if we look at the situation of the patient being in a metabolic complete remission after 2 cycles of ABVD, I think that outside prospective clinical trials, I would not modify the treatment depending on the Deauville score. So we have some prospective clinical trials where a PET negative was Deauville 1 and 2, but the vast majority of them, Deauville 3, is PET negative complete remission, so a metabolic complete remission. Taking into consideration that probably radiotherapy would not be the best option for the patient, basically because of the additional toxicity, also because of the emotional issues related to the past family history, probably I would continue chemotherapy with the patient and I would add 2 additional cycles of ABVD. So we have several examples looking at prospective clinical trials where patients in a PET negative complete remission after 2 cycles of ABVD would eventually benefit from 2 additional cycles. So probably I would give 2 additional cycles of ABVD.
Great, thank you. Leanne, would you do anything differently?
In New Zealand, in Auckland, we've recently, I know, she's an adolescent, young adult, so we have an opportunity also to be in that trial for the Euronet. So as she presented 2 years ago, she would have been eligible, even though she has with early stage Hodgkin's lymphoma with just 2 nodal sites. That's just closed to recruitment, and that used essentially chemotherapy approach with 2 cycles of OE, but followed by 2 cycles of either COPDAC or DCOPDAC. And very minimal numbers then proceeded to radiotherapy. It was PET directed. So that would have been an option for her. If she was treated in our adult service, it would have been ABVD also. But it's very important that it's PET directed, especially as Anna's pointed out. But I think that if she was Deauville 2, for example, after her initial interim PET, then we would just do 1 further cycle of ABVD as per the Rathel study and then stop treatment. Deauville 3, however, she would probably have had 2 more cycles and possibly another PET scan. So I don't think that, the addition of involved field radiotherapy, aside from her history, would have increased her progression-free survival by 3 to 6%, but absolutely no overall survival advantage. So clearly appropriate for PET-directed therapy.
Great, thank you. Astrid.
I also agree with my other colleagues. I think that we have enough evidence to know from the CLGB trial and also from the HD60 that these patients who achieve a negative PET-CT after 2 cycles of ABVD have a PFS over or around 90% without radiotherapy. So there's no doubt that the family history is important, but even if this patient did not have this family history, I would avoid radiotherapy. This patient would be treated in an adult service in our country, so I would add 2 other cycles of ABVD. And also maybe I would do the first PET scan after 3 cycles of ABVD in our institution and stop therapy after 3 cycles if we have a negative PET-CT, and we consider negative PET-CTs for 1 and 2 in this case.
Great, thank you. Kerry. Did we lose Kerry?
She's muted.
Sorry. We've been using a PET adapted approach for the management of limited stage Hodgkin since 2005. And as long as the disease is considered radio encompassable, we would give 2 cycles of ABVD. And if the PET was negative, complete the treatment with 2 further cycles of chemotherapy. And the chance of someone like this being PET negative is about 90% in our experience. So I think the likelihood that she'd be able to be treated with chemotherapy alone would be high. And with excellent outcomes, we reported our experience in hematological a couple of years ago, and the 5-year overall survival was 97%. PFS is sitting at around 90%.
Great, thanks. So I'll tell you that we actually treated this patient with 6 cycles of ABVD because she was a Deauville 3 based on the CLGB study looked at the Deauville score, and those who were Deauville 1 and 2 had about a 95% PFS. And the Deauville 3s did a little bit worse. And this was a very, very anxious young woman because of her history, and she did not have a CTCR if you look back to that old Canadian study where they use CT response. But knowing that 4 cycles of ABVD would be a very standard option in other places. So she's done very well. Yes.
That's a really good point. What is a CR in limited stage versus advanced, because it is a little different. In the limited stage trials, it has been 1 and 2 if you're omitting radiotherapy. So the 3s
Right, in the rapid study, right.
And that's what we do as well. A Deauville 3 in limited stages, we consider that positive and switch to radiotherapy. But at the end of treatment for advanced stage, that's actually considered complete remission. So I would say if the patient said 100%, I never want radiotherapy, I would have done what you did and actually treated with 6 cycles, because if it's Deauville 3, then you're in a situation, well, I can't switch to radiotherapy. I can't add it in this particular patient. But in most scenarios, they're accepting of it, and the chance of actually being Deauville 3, 4, 5 is still only about 10%. But I think that's a good.
Excellent. All right, so let's go on to the next case. So this is a 59-year-old male who presents with stage 4A disease. He noted a left neck node on self-exam. Around the same time developed some quite severe chest pain on the right. Had a chest CT scan that showed adenopathy in the supraclavicular and mediastinal regions with mild splenomegaly. At a biopsy that showed it was a core biopsy, so they weren't able to subclassify his classic Hodgkin lymphoma. He had a PET scan that you can see here. He had disease above and below the diaphragm. He had uptake in a pulmonary nodule, ribs, spine, and had a soft tissue mass associated with the right second rib. He had small bilateral pleural effusions and heterogeneous uptake throughout the axial and appendicular skeleton. So his IPS was a 3 for male sex, age greater than or equal to 45, and stage 4 disease. So Leanne, how would you approach a patient like this in New Zealand?
A 59-year-old male, 4A, but in some extranodal sites. I never liked lung involvement. It always makes me nervous. However, he is 59, so I think I would still go with ABVD rather than Berkahn. We tend to have an arbitrary kind of a split if people are fit enough for Berkahn, escalated Berkahn, to use the IPS score of 4 or more, and he's a 3. So we would have gone with ABVD and then PET-directed approach as per the Rathel study. So if provided he was Deauville 1 to 3 after 2 cycles of ABVD, he would have had his bleomycin omitted for the final 4 cycles. I note he's CD30 positive, and with the Echelon 1 trial, the substitution of brentuximab, obviously for bleomycin, did improve the progression-free survival from 77 to 82%, and it is licensed for this indication by the FDA, but that is not available in New Zealand. I'll be very interested to hear how many other of you have that available frontline, but obviously that would be enticing in this situation.
Great, thank you. Astrid, how would you manage him at your center?
Okay, so this is a patient in which we have different options. We can do a PET-adapted approach, starting with ABVD, as Leanne said, or with BCOP. And now we have this newer option of adding BV in first line. And in our country, this is reimbursed. So I could choose to do the echelon 1 treatment. I am still, when using VV, I still think about the importance of doing a PET-adapted approach, and it's difficult to just do 6 cycles without doing any adaptation of treatment regarding response to treatment. But although I do have these options, I still, in my clinical practice, still treat most of these patients with advanced HTC, starting with ABVD and doing a PET-adapted approach. So the big problem is, and when I think about this patient, the big problem is if this patient is PET positive after the first cycles of ABVD, because we know that even if we do escalate to BCOP, the results are still not good. So we are not improving a lot when we escalate. We do have some improvement other than continuing with ABVD, but no more than 63 or 65% PFS. So that's my only worry when I start patients with ABVD. But I have to say that in my clinical practice, I do start with ABVD and do a PET-adapted approach.
Great, thank you. Kerry, what would you do? Oh, you're muted. Thank you.
Probably should just leave it on.
Leave it on.
If I had upfront BV available, I would give AVD and brentuximab vedotin as per echelon 1. It's Health Canada approved, but not yet provincially funded. So we actually do not have access to it. So in practice, I would treat someone like this with ABVD, and as others have indicated, PET-adapted approach with dropping bleomycin after 2 cycles. We have not standardly escalated to be a COP, and I would, even if we did, I'd be nervous in that 59-year-old as being 1 year away from being technically elderly. But we do have a clinical trial of switching to AVD and nivolumab in collaboration with Memorial Sloan Kettering, which I think would be appealing.
Great, thank you. Anna, what would you do in Spain?
Okay, so basically Spain is an ABVD treating country, so there are not so many centers using BCOP escalated, even for patients with more than 3 risk factors following IPS. We are using PET-adapted strategies, so in principle I would use ABVD ×2, and then if PET is negative, I would drop bleomycin, and if PET is positive, following the Rathel trial, I would escalate to BCOP escalated. I have to say that people are a little bit reluctant to escalate to BCOP escalated because there are not so many centers used to use BCOP escalated. And I think that we have to acknowledge that you need to have some skills to try to keep the treatment on time using quite a lot of support. And small centers in Spain are really not used at all. So we have some problems there. If the patient is PET positive after 2 cycles of ABVD, how this BCOP escalated is going to be managed. After having said that, we don't have the possibility to use BB-ABD following the echelon 1 trial because it's still not reimbursed in Spain. I think, or my guess is when it's being reimbursed, probably quite a lot of these patients are going to be moved to BB-ABD. Well, first of all, because the data coming from the echelon 1 trial, then the no need eventually to have to escalate to BCOP escalated in these patients that are PET positive after 2 cycles of ABVD. Although I really like the PET-adapted strategies, and unfortunately the echelon 1 trial is not a PET-adapted strategy. So nowadays, ABVD and then escalate or de-escalate depending on the result of PET2.
Great. So it sounds like we have similar approaches with this gentleman because he was 59 and he had stage 4 disease, and we can get brentuximab plus AVD in the US as standard of care. I opted to treat him with that. I was worried about his disease. He was quite symptomatic. And after 2 cycles of BV-AVD, he was PET negative. So we did do a risk-adapted approach in some ways because he had a lot of toxicity. So I think that is the issue with this combination. He had significant peripheral neuropathy. He had a lot of GI toxicity that wasn't sort of your standard nausea that you can really well manage with the therapies that we have today, but he had, you know, he just felt really poorly. So we ended up discontinuing the brentuximab after cycle 3. He had a lot of achiness and just really his performance status had declined pretty dramatically throughout the course, but we finished out the 6 cycles and he remains in remission now about 6 months out from completing treatment. But, you know, I think his age, it really does highlight that the toxicity profile is significantly worse than we obviously gave him growth factors and he's done well, but it was an interesting case. So moving on to our next case, this is a 33-year-old woman whom I met during her pregnancy. She had presented initially with severe pruritus. We all see a few patients like this a year and had seen multiple different providers and had even gotten light therapy and all kinds of topical and oral therapies. And then about 6 months into this, she noted a neck node, at which time she was 29 weeks pregnant, had a core biopsy, which again showed classic Hodgkin lymphoma. She, because obviously we can't do CTs or PET during pregnancy, she had an MRI that showed her disease was localized to the bilateral neck and chest with, she just met criteria for bulky with a 10-centimeter mediastinal mass. She did not have B symptoms. Her sedimentation rate was 96, though, you know, whether the pregnancy may have affected that. If you calculate her IPS, even though this is an early stage patient, she had one risk factor, that of low albumin. So here we have a 29-week pregnant bulky stage 2A patient. What would you do? So we'll start with Astrid.
Okay, so this is a challenging case, and I think the outcomes for mother and child following diagnosis of Hodgkin lymphoma during pregnancy are under investigated, so we don't know as much as we would like to know. There has recently been a publication showing that the outcome of the patients, the mothers treated with Hodgkin lymphoma, are just the same as those who are treated not during pregnancy, either whether they were treated during pregnancy or after delivery. So I think my first choice in a pregnant woman would always be to try to wait until delivery to start treatment. And in this case, with such a big mediastinal mass and being that she is in 29 weeks of pregnancy, so there's quite a few weeks more until the baby can be delivered, I would start treatment with ABVD, and I think that we have enough information to think that at this time, being that in 29 weeks, it could be safe to start treatment. So I would recommend to start with ABVD.
And how many cycles would you give? And would you, because without being able to do an early interim PET?
Well, maybe I will start with the first 3. I usually evaluate patients after the first 3 cycles because in our clinical trial, we do it that way. So I would try, I'll have to count the weeks, but I think that I could do the first 3 cycles and then evaluate with an interim CT if she has already done the delivery.
Great. All right, thank you. Kerry.
Yeah, I agree. With the symptoms she's having in the bulky mask, I don't think this is somebody you'd be able to watch and treat after. So I think there has been cumulative evidence of ABVD and safety and outcome. Maybe a little more preterm labor, but it's hard to tell because these patients are often, planned to have early deliveries. So I would treat with ABVD. I would be sort of planning to get them to 37 weeks. And I think the guidelines are to try not to give chemotherapy within about 3 weeks, so you avoid neutropenia during delivery. And then I would stage after delivery continue. So I would treat someone like this with full 6 cycles with bulky disease. We treat bulky stage 2s as advanced. So I would plan that from the get-go.
Great. Thank you. Anna.
I think that I don't have a lot of things to add to what it has been said. I think that this patient probably cannot wait after having had the diagnosis to start treatment. So it's 29 weeks pregnant. So in principle, we have just avoided the first and eventually the second trimester, which are the most complicated basically for the child. So I would start probably right away without really further delay with ABVD. I would evaluate the patient because this is what we normally do. And I am just thinking about the first case that we discussed. We normally reevaluate these patients after 3 cycles of ABVD. And probably just because it's stage 2A, but with bulky disease, I would eventually continue until up to 6 cycles of ABVD, of course, taking into consideration that probably this patient is going to have an pre-planned delivery and then checking, of course, neutropenia and toxicity of ABVD during this interim period.
Great. Thank you. And Leanne.
Yeah, similar. We also would start with ABVD. I'm quite comfortable with using this ABVD in second and third trimesters, although it's been understudied, as pointed out. There's quite large series now published that's showing it's safe for both mother and fetus as far as has been determined. It's really important that you have a multidisciplinary team. I think that's the big issue here with her management. We have very close connections with our high-risk maternity clinic to time the delivery, to do all the, to make sure we have coordinated care, whether she's going to have the epidural, especially with the mediastinal mass, or if she has a cesarean section, you know, would she, all the anesthetic type issues need to be thought out. And with, as Kerry says, I would probably stop. I think she only had time for 2 cycles, and then I would stop, and then you get your interim PET really after 2, and then I do 6 cycles, but she could go down to ABD if she was over 1 to 3.
Great, thank you. So that's, you know, exactly what we did. We have a very good maternal fetal medicine group and started her on ABVD, and she had pretty quick resolution of her pruritus and tolerated therapy well. She delivered, I believe it was after cycle 2B, and we were able to keep her fairly close to being on time because she was not neutropenic at the time of her delivery, and we were watching her counts closely. And she did very well. Sorry, there we go. So she actually got 6 cycles of ABVD because this was just prior to Rathel being published, but did develop some bleomycin pulmonary toxicity with discontinuation of that drug after cycle 3B. We were able to get actually she was delivered after 2 cycles, so we got a PET as soon as she delivered, and she was PET negative. So she did very well and had asked to have a restaging. She really wanted surveillance imaging, which we've really moved away from doing in an asymptomatic patient. But at the 2-year mark, she really wanted to get a scan, so we did that, and it was completely negative. And then about 9 months later, she developed, no, it was even less than that. She developed progressive respiratory symptoms. She has a history of asthma. She was treated with inhalers and oral steroids and lots of therapy before someone actually got a chest x-ray. I wasn't aware that this was all going on. And she had a large hilar mass and had a PET scan shown here, and had really pretty significant disease with some upper abdominal disease as well. We did a endoscopic biopsy, which was highly suspicious. It wasn't absolutely diagnostic of recurrence, but it didn't seem that there was much else on the differential diagnosis. So now we are 3 years after she completed 6 cycles of ABVD. How would you treat her at this point, Kerry?
Yeah, I mean, we would treat this standardly for relapsed Hodgkin's lymphoma with salvage chemotherapy, followed by high-dose chemotherapy and stem cell transplant. So our salvage chemotherapy in Canada is GDP. It's an outpatient regimen. And as long as she's responding, we would go to transplant.
Great. Anna, what would you use for second line therapy in a situation like this?
So basically, I would go ahead for salvage chemotherapy and autologous stem cell transplantation. The most frequently used salvage protocol in Spain is ISHA. We are not admitting these patients, but I recognize that ISHA has more hematological toxicity and extra hematological toxicity than GDP. There are some centers admitting these patients. And now we have a prospective clinical trial that it's randomizing ISHA versus brentuximab vedotin ISHA. I mean, to try to see let's say, what it seems it might happen from the data that we have from phase 2 prospective clinical trials, that the complete remission, the metabolic complete remission rate increases with the addition of brentuximab vedotin in this setting. Outside prospective clinical trials with ISHA, 2 to 3 cycles, and then autologous stem cell transplant.
Great. Thank you. Leanne, would you do anything different?
Not really. I think we sort of cycle around as per the flavor of the month a little. We used to do ice salvage. Now we probably do DHAP, but more and more we're looking at GDP thinking, well, that looks easier and just as good. So I don't think there's a right chemotherapy salvage, but it clearly will be chemotherapy rather than anything targeted.
Okay, great. Astrid, what would you do?
Okay, well, I have nothing extra to add to this. In our clinical practice, we do ICE as a salvage therapy. I think this patient doesn't have a high-risk relapse because 3 years have gone by since the last treatment, so it's a late relapse, and that is good. But now, when patients relapse, in my mind, I think whether adding BV to chemotherapy, if it was available, would that improve outcome? Anna just told us about her clinical trial, which I think is very important because most clinical trials with BV plus chemotherapy in this setting are just phase 2. So I'm still not sure whether we are adding benefit if we could add BV to salvage chemotherapy. I'm not sure what all of you think about this. We are not doing it in our clinical practice. I would do ICE. I would really try to achieve a PET negative before autologous stem cell transplantation. If not, I would go on to a second line of salvage chemotherapy. We're not offering a transplant to patients who do not achieve a negative PET-CT after first line of salvage chemotherapy. But I think the big question is whether BV plus chemotherapy in this setting would add any benefits. Not sure what the rest do or think about all of these publications in phase 2, which show very good results with BV plus different salvage chemotherapy.
Yeah, so it's an interesting question because we participated in the brentuximab plus bendamustine study and found a fair bit of toxicity when giving those two agents together. Even though it was an outpatient regimen, we saw a lot of infusion-related reactions, and patients would often not be able to complete the second cycle of salvage, or we had some patients who required hospitalization with hypotension and sort of inflammatory type symptoms. So we have sort of abandoned that. And the way that we have approached this, at least within our group, is if people have a later relapse, after a year, we would use ICE. So I gave this patient ICE. I think any of the regimens are probably equivalent. That's just the one that we give it as an outpatient. For patients who relapse early, either primary refractory or relapse within the first year, we will often try to get brentuximab plus nivolumab. Though I'm sure you all saw the data at ASH with pembrolizumab plus GVD, and I think that is, at least in phase 2 studies, looks very appealing. So we'll have to see how that kind of plays out. So for for my patient, she got 2 cycles of ice. This was quite recently, and she had this very unusual toxicity where she developed headaches that no other neurologic symptoms, but they were temporally related to the ice and persisted for days. And she had positional hypotension when she laid down, and we just couldn't quite figure out what was going on. But when we stopped the ice, she was feeling better. And we repeated her PET, and she had complete disappearance of all of her disease except this solitary site of disease, which was felt to be an internal mammary node. And there was some question as to whether this could possibly be even more avid than it was on the baseline scan. So with this, what would you do? Anna.
Okay, so first of all, I have to say that I have been thinking a lot about this patient when I was reviewing the cases before. I think that's, let's say, it's really a challenging case because, of course, if you have WiLing and you have the feeling that this node, I mean, it's brighter than before starting ice, I mean, we have to eventually admit that the patient has progressive disease. I think that we agree, and we may discuss that we don't like to take patients into an autologous stem cell transplantation if we think that the patient has progressive disease. So the patient would eventually be candidate for second-line salvage treatment. And we can discuss that because, of course, we have seen that our options in the prior question has been a little bit different. So probably our approach would also be different in terms of second-line salvage treatment. But the patient, let's say, has this only positive lymph node, and the patient has not received radiotherapy before. So many times when I talk to Astrid, sometimes we tend to forget the potential role of radiotherapy in patients with Hodgkin lymphoma. And nowadays, with all the PET adaptive strategies, probably we have more patients in second line that have never seen radiotherapy before. So that could be, let's say, eventually another option to try to irradiate this lymph node and to eventually go ahead with the autologous stem cell transplantation without any further treatment. So I'm not 100% sure. I would like to discuss that, but I really, let's say, I probably would think that in this specific case, this could be an option just because of the localized nature of the disease after the cycles of ice before autologous transplant.
Great, thank you. Leanne, what would you do?
Yeah, I mean, she clearly, we would try and, you know, we wouldn't proceed to transplant with the WiLing. I thought about radiotherapy too, because it's just such a small site, Anna. But then I was worried, you know, with the bleo lung she'd had before. I wasn't sure about the lung radiotherapy, even though it would be involved site. So I would have asked my radiation colleagues about that. I guess I was in New Zealand, we would probably have to give her a second-line chemotherapy salvage. Although, as you're aware, you know, there are other like pembrolizumab or brentuximab, which can be used after just one prior salvage chemotherapy. Is licensed for that. But I will be mindful of her past history of the bleo lung and would be very careful about selecting my next choice of therapy, not to aggravate that, because that's a very distressing and quite scary pneumonitis. Isn't good in any age group.
Great, thank you. Astrid.
I also think this is a very challenging case, and there's no doubt that we all think about radiotherapy when we look at a localized stage. And also thinking about biopsying this patient, but in this case, I think the site is not accessible for to have an easy biopsy. So, and it's also in a previously a hypermetabolic region. So I would probably assume this is residual disease. As said before, I think PET before autologous stem cell transplantation is probably the most relevant prognostic factor. So I would not offer, I usually do not like to offer patients with a positive PET scan to go on to a autologous stem cell transplantation. So I would decide to go on to a second-line therapy. And at this time, BV brentuximab vedotin is authorized in our country because the patient has already received 2 lines of chemotherapy. So I would probably think of offering BV monotherapy for 2 or 3 cycles, and try to achieve a negative PET-CT and consolidate with autologous stem cell transplantation. And after autologous stem cell transplantation, my question would be whether radiotherapy is beneficial after achieving a negative PET-CT. I think that is an unanswered question. And my choice would be VV and try to reach autologous stem cell transplantation.
Great. Kerry.
Yeah, I agree that this one's tough because you've given us a hedgy PET report as well. But just assuming that we're really, we are convinced that this is worsening disease, I'm not happy going into transplant with worsening disease. So I would want to give another line of treatment. And this is a scenario where we can get one-offs to access brentuximab vedotin. So that's what I would do. This is also somebody I would consider brentuximab as consolidation after transplant as well, because they're not in a complete remission. Even though it was a late relapse, this is a worry for me. So I would consider it after the transplant.
Great, thanks. Yeah, so I certainly thought about all of those options, including radiotherapy. I think prior to having some of the novel agents, that would have been what we would have done, is to do radiotherapy before autologous transplant, knowing that there are increased risk of toxicity. But what we decided to do, and we can get this in the US if you petition the insurance, is to give BV-nivo because we really wanted to incorporate a checkpoint inhibitor before autologous transplant, given some of this emerging, though retrospective data in general that perhaps checkpoint inhibitors may enhance chemotherapy sensitivity. And we have the BV-nivo data from Alex Herrera's study looking at those patients who went directly to autologous stem cell transplant did better than we might have anticipated. So she is in the midst of BV-nivo. She's now had 4 cycles. She's had some peripheral neuropathy. She's otherwise tolerated it quite well with some pruritus that we were able to manage. And she is coming in next week for her PET scan. I think if she has residual disease and it's still in that area, I would certainly plan on radiotherapy. If not, we'll plan to proceed to stem cell transplant. But it's a bit of a nerve-wracking case.
And I just wanted to make one other comment because of the recent data of the Pembro versus BV phase 3 study. So outside of the US, it's probably impossible for us to get BV-nivo because it's phase 2 data. But now, so we have phase 3 data showing that Pembro is superior to BV in relapse, but also transplant ineligible patients, which you could argue this patient would become transplant ineligible. So I think in the future, we will probably have that available in Canada and may move forward in patients who don't get an adequate response to chemo before BV. I suspect that's what we would do. Yeah, I'm just curious, outside of the US, do you suspect you'll be able to get pembrolizumab based on that trial?
I don't think, no.
No way.
Agree.
We could get it maybe for pre-allo, what if they failed a previous autograft, that's where but we can not get either agent prior to autologous transplant until you've exhausted all the chemotherapy options. But I agree, the Keynote trial, that pembrolizumab is clearly the salvage winner over brentuximab, the much higher overall response rate. I mean, we worry about it going into allo because of the increased risk of GVHD. I was just going to ask Anne whether you were going to consider, given she didn't get in neuropathy, whether you were going to, like Kerry, consider giving brentuximab post-transplant. Because I wasn't thinking she was I'm just not quite sure of the criteria you're applying. It's not available in New Zealand, so I haven't given it too much thought as to what's the high-risk group that is recommended for that.
Yeah, and I think if you look at the modified criteria, because she required 2 different salvage regimens, I think you could use that to justify giving it. And we, you know, in the US, what we can give is really determined by the NCCN guidelines. And if things are included there, then they are typically covered by insurance, even if they're off-label. And I think the issue with giving checkpoint inhibitor alone, if you are trying to, you know, I think the question becomes, what is the value of a metabolic complete remission pre-auto when you're using checkpoint inhibitors? And is it this, you know, do you need that same metabolic CR? And I think that's something we just don't know at this point. So let's move on to the next case. This is a 74-year-old man who has stage 2A NS-Hodgkin lymphoma. He has some hypertension, obesity, sleep apnea, and he'd had some sort of non-specific symptoms dating back to early 2020 and hadn't really, probably because of COVID, had been reticent to be evaluated. And his son, who is a radiation oncologist and is just fantastically supportive and great, recommended that he go to the emergency department after he had one of these episodes. And on his way to the emergency department, he rear-ended the car in front of him and ended up having a trauma workup that was notable for some pelvic lymphadenopathy on the left greater than the right. So he underwent an excisional biopsy that revealed classic Hodgkin lymphoma. Interesting, it was EBER positive, though it was a nodular sclerosis subtype, so an unusual pattern. He had a PET CT scan that you can see on the screen here, and he had disease in the bilateral inguinal and iliac regions, left greater than right. There's some non-specific uptake in the bowel over there on the right. His baseline laboratory studies were notable for a SED rate of 53. He had normal CBC, his creatinine was normal, his albumin was a little bit low at 3.7. So we have a 74-year-old man, 2A NS-Hodgkin lymphoma, disease below the diaphragm. How would you treat? So let's start with Leanne.
Yeah, so I would be interested in scoring his comorbidities formally on a LaCasce score. I think that although he's stage 2A, the disease is below the diaphragm, which is a worse prognosis than above the diaphragm. I don't think his disease is particularly encompassable in the radiation field, but again, I'd have to defer to my rad-onc colleagues. He's 74. I mean, he's probably, we don't really give ABVD to 74-year-olds in my town, but he could be considered if he was super fit. And in that case, you know, I prefer that he had BV, ABVD, or even BV CAP would be, you know, when I was looking around for potential options. So none of the brentuximab would be available to us. This case highlights the unmet need that we have with the elderly with Hodgkin's. You know, it's a huge gap. They do worse than younger people, and yet they don't have the good therapies because they don't tolerate the standard chemotherapy. And that's one of the reasons that we instigated an investigator-initiated trial with Michael Dickinson, the Plymouth trial, looking at upfront pembrolizumab as a single agent in patients who are over 70 or unfit for ABVD, and that's ongoing. Brentuximab as a single agent has also been used with like 10-month progression-free survival with single agent alone in people like this. But I'd be mindful. I think, you know, if you want the answer, we would give him probably ABVD or possibly Claudvac as our default chemotherapy for those not fit.
Great, thank you. Astrid, how would you manage him?
Okay, so I think it's important to know whether his pulmonary function and his cardiac function are okay to receive ABVD, but we do treat these older patients with ABVD, with a PET-adapted approach, trying to lower down the number of chemotherapy. So I would do 3 cycles of ABVD or drop bleomycin if there's any pulmonary toxicity, and stop therapy after 3 cycles if he achieves a negative PET-CT.
Great, thank you. Kerry?
Yeah, I actually don't give bleomycin to this age group. I'm very nervous about toxicity. I get nervous around age 60 and 74. I think the risk is moderate. We know from HD 13 that there is a slight compromise if you take out bleomycin, but it's 3.9%. So AVD is still curable. This is the type of patient we would review in our multidisciplinary clinic and ask the radiation oncologist, is this radiocompensable? If it is, I would actually give AVD and involved field radiotherapy as my first choice, trying to limit the number of cycles of chemotherapy. This is also somebody I would get growth factors with, especially since bleo's already been taken out. I'm not as worried about pulmonary toxicity.
Great, thank you. Anna?
So I think that I agree with Kerry. So we would be a little bit nervous to use ABVD in this particular patient because of the age. And although we don't have, let's say, clear data on the comorbidities, probably this patient is not 100% fit. So probably adding bleomycin is going to add quite a lot of toxicity. This would be the population or the group of patients where the introduction of new drugs in first-line therapy would be really interesting, with the objective to try to keep the efficacy that we know that with conventional protocols is not the same as for the younger population of patients, and to decrease the toxicity. But unfortunately, we cannot use BV or NIVO or Pembro outside prospective clinical trials. So we will be using basically ABD, omitting bleomycin, and then potentially evaluating radiotherapy, depending on, on the also the evaluation of the radiation oncologists.
Great. So I agree, we agree with Anna and Kerry regarding the use of bleomycin over 70 for sure, and even over 60 or 65 get a bit nervous. I think everyone has highlighted all the issues. He's in relatively good shape, but not, his performance status was 1. His, wife recently passed away. He's was a little bit complicated from a psychosocial perspective as well. But what we opted to do, and again, this is something that we can do in the US, is to follow the Andy Evans phase 2 study that was published in JCO a couple years ago, giving sequential BV-AVD, because giving the two together in someone this age, I think would have been very difficult. So we gave him 2 cycles of BV, and he had a nice partial response, and then did 2 cycles of AVD and did another PET scan. And he had complete resolution of all of his adenopathy, with the exception of 1 focal area within the left groin, which was in the region of his initial biopsy. And he had had some wound healing issues. It wasn't exactly clear if it was a lymph node or not. During the course of his treatment, he developed atrial fibrillation and some orthostasis. He was on a number of antihypertensives and Flomax that seemed to complicate that. So we opted to do 2 more cycles of AVD and got another PET scan. And his repeat PET scan shows a relatively stable lesion in the groin, nothing anywhere else. So we actually sent him for a biopsy, which he had this week, just to see whether that was really residual disease. But I think regardless, we've now involved our radiation oncologist, Andrea Ng, who's just really phenomenally collaborative and great. And we're going to loop in his son who focuses on prostate radiation, and see whether what the field would look like. It does, it's bilateral pelvis, so we want to be mindful of his bone marrow. So I think we're going to have a joint conference this week and decide I think if there is no residual disease there, I might be tempted to add a couple of doses of BV at the end following the study. They didn't incorporate radiotherapy, and a lot of patients in that study had to come off treatment early for toxicity and got, fewer than 6 cycles of AVD. But he's tolerated it other than the AFib really well, and hopefully we'll get him into a complete remission. So we probably have time very quickly for one last case. And I'll just to quickly summarize, this is basically a 64-year-old male who's had longstanding sort of waxing and waning lymphadenopathy, which led him to ignore these bilateral inguinal nodes that were, between, around 4 centimeters bilaterally. Eventually, because of COVID, there was a delay in getting him to a biopsy. And the biopsy actually showed nodular lymphocyte predominant Hodgkin lymphoma. So he had a PET scan after his surgery where they completely resected the node on the left, and he has disease on the right. He's otherwise completely asymptomatic. So what would you do with this patient? And we'll start with Astrid.
Okay, so this is also challenging, knowing that the evidence-based recommendations are difficult in this group of patients due to the small number of patients usually included within the classical Hodgkin lymphoma groups. So there are multiple controversies on the management. But what we do know is that in a long-term follow-up, most of these patients have very good outcome. And I think the German group has taught us that if we treat these patients just the same as classical Hodgkin lymphoma, these patients do very well. They can also do very good with CHOP or the addition or not of rituximab, or in some cases, radiotherapy in localized stages. But I think this patient has bilateral disease, so radiotherapy will not be my first option. And I think I would just treat him as I do with classical Hodgkin lymphoma patients and start with AVAD.
Great, thanks. Kerry, what would you do with a patient like this?
It's an interesting case. I mean, I'm struck by the data from Memorial Sloan Kettering that at the end of the day, no matter what we do, the overall survival is excellent and patients rarely die of their disease. So kind of less is more. So he's had treatment already on one side with complete excision. I would actually be tempted just to radiate the remaining disease and watch him and perhaps reserve any systemic treatment for more widespread recurrence.
Great, thanks. Anna, how would you approach this patient?
So I would also probably do radiation on the disease that it's being left after the contralateral excision. So, I mean, at the end, the overall survival is going to be really very good. Probably the patient is going to relapse anyway. And just because of the localized disease at the time point, although we have to acknowledge that it's 4.4 centimeters, I think that's the largest diameter. Probably I would try to irradiate, leave the patient alone, and then if the patient relapses, probably go with chemotherapy, either ABVD or CHOP-based protocols.
Great, thanks. Leanne.
Oh, well, I would think, yeah, agree with Kerry, probably a low-grade lymphoma essentially, and although he's stage 2 and technically you should give rituximab and RCVP, he's been completely excised on the left, so I would just go for involved site on the right and not give him any adjuvant chemotherapy. And if I had to give chemotherapy when he does relapse, I'd give him RCVP.
That's great. I think I was also struck by the paper out of MSK really suggesting that we need to not overtreat these patients. And this was really, came up during the pandemic. So we did something rather unconventional and spoke with our radiation oncologist, again, Andrea Ng, and we decided to give him 200 times 2, like an indolent lymphoma dose to the bilateral groin. He didn't have a complete excision where we know for sure that there wasn't any residual disease there. I think we always debate this in this particular entity, but we thought, you know, he really would have no toxicity from that approach. And we can see how he does, knowing that he could always be irradiated, particularly to the right-hand side, to a higher dose, and we would prevent him multiple trips for radiation. So he completed his therapy and is about to have a repeat PET scan about 4 months after completing his radiation. So we're all really interested to see what we're going to find here. And suspect he will need systemic therapy probably in the future. And we tend to use a more alkylator-based regimens with rituximab as well. So I think we are just out of time, but I want to thank all of the panel because that was just an amazing discussion. And I learned so much just from hearing how you do things. I think there are a lot of similarities in how we think, but some differences in regionally, and it's just fascinating to hear your perspectives. So thank you so much.
Thank you for the invitation.
Thank you, Anna.
Thank you. Thanks very much.
Thanks.
And I would just add, I'm sorry, I sort of ignored the chat because I was trying to pay attention to what everybody was saying really carefully. So we do have one more session left in Hodgkin, which will be on February 17th. And it's a particularly, I think, interesting session where we're going to have interviews of Dr. Jane Winter from Northwestern and Dr. Ranjana Advani from Stanford are going to be interviewed by two more junior colleagues. Dr. Pam Allen will interview Dr. Winters and Dr. Crombie will interview Dr. Advani, and to hear about sort of their careers over time in general, and then to talk about mentorship. So we hope everyone will join us for that session on the 17th or the 18th, depending on where in the world you are. So
Great.
thank you.
Thank
We'd
you.
also like again to thank our
Take care.
sponsors,
Bye.
MSD and Roche. Thank you.